primarily in terms of that's primarily the overall topic which we will be really looking at today. And every year on this day reminds us of the global commitment towards the improving diabetes awareness, early diagnosis, and better clinical outcome. And this year theme of World Diabetes Day emphasizes on access to quality care. And that is exactly what we are trying to do today, to share the credible evidence-based insights to collectively strengthen the fight against diabetes. I'm extremely delighted to welcome Dr. S. Satyaraj, having over 20 years of practice in clinical nutrition, and he heads the clinical nutrition departments of HCG Cancer Hospital. And she's also, I think it's my privilege to congratulate her. She is the Secretary Select of the Indian Society of Enteral Parental Nutrition. Congratulations, Dr. Esther. I think a lot being primarily looked at in this regard from you in terms of various aspects of clinical nutrition. Of course, regarding her academic credentials, she holds a PhD of clinical nutrition and registered dietitian from Indian Dietetic Association. She has various publications and presentations done on national as well as the international forums in this regard. So I would invite and request Dr. Esther to take over the session from here.
Yes.
And take things forward.
Yes.
Thank you.
Thank you. Thank you, Ramesh. Thank you, Pulse, for this opportunity on World Diabetes Day. Thank you, Dr. Abhilash and Dr. Manju for joining us. And all the participants, I understand it's a busy Friday afternoon and for taking time off and joining us. Thank you so much. So it's a very interesting topic. We are talking about going beyond A1C. Now, for the last few decades, A1C is a standard measure for diabetes control. And now we kind of realize that A1C alone is not enough. It is the peaks and the crashes that we experience with blood glucose that also plays a very important role in long-term outcomes and the overall metabolic health of the patients. So on this note, I will introduce Dr. Abhilash. He is the first speaker. Then we will have Manju, who's a good friend of mine. She'll be the second speaker. But Dr. Abhilash, thank you so much for joining us. He is an MD in internal medicine. He is also a PG diploma in diabetology. He is the consultant physician and diabetologist at Indira Gandhi Cooperative Hospital, Kochi. Raju, can you put the slides of Dr. Abhilash? Then people can see what I'm introducing him as.
Yes, ma'am. Yes.
Yeah. So Dr. Abhilash has got a decade of experience as a consultant, physician and diabetologist. He is currently at Indira Gandhi Cooperative Hospital, Kochi. And he is an MD in internal medicine from Mahatma Gandhi University and a PG diploma in diabetology from Annamale. He is recognized for his excellence in diabetes care and internal medicine education and has been an invited speaker in many national and international medical conferences. And he is known for his work in comprehensive diabetes management and his focus in integrating clinical data with the patient care and monitoring tools to optimize the outcomes. So we have some eminent speakers today who can help in understanding how these peaks and crashes happen with diabetes management. And on that note, I hand it over to Dr. Abhilash. Raju, we still can't see the slides, sir.
Thank you, Dr. Esther. Thank you for the introduction. I welcome everybody who's come online for this webinar. I think I'll wait till the slides are coming on now. Hold on. Can you put it full screen? Yeah. Okay. So it's basically our topic today is postprandial glucose control management, the missing link in diabetes, usually because easier for everybody earlier used to be fasting, but now they have come up with the ideology that even postprandial might be a better indicator while compared to the HbA1c control. Can we go to the first slide? The next slide, please. I don't know who's. Yeah. Okay, so as they say, the glycemic roller coaster, that usually if you're looking at a CGM, you will see it is an actual roller coaster. So it is a repeated excursion where you don't have just one simple meal spike. That is, maybe after lunch you have a spike, or after dinner you have a spike. But these accumulation of these spikes creates the instability in the metabolic scenario. Clinical impact of this is large excursions, which is symptomatic and mostly not known if the patient is not on CGM, is it increases the long-term cardiovascular and microvascular risk. It's not visible initially when we're looking only at the fasting, though in our setting we have our limitations. Metabolic resilience, poor metabolic resilience and increased glycemic variability. It is in the indicator of inadequate diabetic control, and which requires a stricter therapeutic intervention. Can we go to the next? Okay, what is postprandial glucose? Postprandial glucose, I mean, everybody knows this by now that, it is, we have set it at 2 hour. It serves as a glycemic control marker. Because earlier, even though it was fasting and HbA1c. Postprandial earlier used to be used before HbA1c, it was fasting blood glucose and PPBS, that is postprandial glucose, which ADA guidelines say 180. A lot of our labs go for below 200. What is distinct from FPG and random glucose is that it shows the mealtime glycemic spike, and also shows as a indicator of dysglycemia. That is, even though the fasting might be okay, after meals the spikes might also add to HbA1c, which we have seen in a lot of patients where fasting looks normal, but the HbA1c is climbing. And also, it is the earliest detectable sign of declining beta cell function and increasing insulin resistance preceding to FPG abnormalities. Next. Okay, now the question has always been why PPG? Because it is kind of hard in a working population to do this because it's actually after breakfast. But for people with high HbA, I usually suggest with people with very high HbA1c on insulin, they go for PPPG also. It substantially it is for total hyperglycemia patients, which, like I said, the excursion might show that the HbA1c climbs while the fasting glucose is still at normal. Pathophysiological cascade is that it triggers higher PPG triggers oxidative stress, endothelial dysfunction, systemic inflammation, and platelet activation, which is basically the vascular damage cascade. The early control of postprandial reduces the vascular risk even before the HbA1c rises significantly, which is a therapeutic window for active and strict intervention. We go to the next slide, please. And now the question comes in whether it is postprandial or is it versus fasting and HbA1c. Postprandial, it strongly correlates with HbA1c. So it serves as a primary driver of the glycemic burden in especially the early disease stages. And that too in patients with less than 7.5 is where you would have, the fasting sugar will remain normal, but the spikes that you will see is post meal 2 hours. Progressive disease. As the HbA1c rises, the fasting glucose will play increasing role. For example, anything above 8, you will see the fasting glucose above 150, 160. PPG still will show the variability and the complications risk. There were some of them, even though they are 150, I've seen patients who are either on insulin or on OHAs or even the newer OHAs, spikes will go above 300. Comprehensive management, that is managing both FPG and PPG synergetically, it delivers a superior overall glycemic control and reduce variability. And it causes fewer micro and macrovascular complications compared to targeting either alone, even though it is not possible for everybody to do, but that would be the guidelines. Next. Okay, this is the mechanism of damage which I had briefed before, how the PPG excursion causes damage. So different pathophysiological pathways are there. Trust me, it is boring, but I'll go through it fast. Oxidative stress, that is reactive oxygen species, is it overwhelms the cellular antioxidant defenses, damages the proteins, lipids, and DNA, which is usually non-reversible. Endothelial dysfunction, the decreased nitric oxide bioavailability, increased sedation, it impairs vasodilation and causes plaque formation, which later causes cardiovascular complications. Inflammation, usually it is cytokine surge after the peak of glucose happens. It activates inflammatory cascade, mostly IL-6, tumor necrosis factor alpha, C-reactive protein. And all of this is systemic inflammation. Prothrombic changes, again, it gives rise to cardiovascular complications because coagulation factor activity and platelet reactivity, it increases. So thrombosis, stroke, cardiovascular disease, all of this is a part of it. Lipotoxicity is again triglycerides, elevated postprandial triglyceride, chylomicron remnants causes atherosclerosis, and the progression of atherosclerosis is accelerated by increased spikes. Can we go to the next? Okay, now the organ level consequences. Initial one, most important one, cardiovascular. PPG independently predicts atherosclerosis and cardiovascular events, and it is a modifiable risk factor beyond like your lipid measurement and blood pressure targets. Main reason being endothelial injury, repeatedly from the glucose spikes, which causes plaques, increase the rupture risk of already existing plaques, and acute coronary syndrome when the high sugar levels are present. Early detection, that is even mild elevation in postprandial in an impaired glucose tolerant patient is linked to early atherosclerotic changes, and this gives you a longer and much earlier window for intervention and treatment rather than it would cause more of a prevention than going in for a cure later. Next slide. Okay, now the rest come in as organ level together: kidney, retina, and the nephro part of it, nervous part of it. Sorry, kidney damage, the hyperfiltration, which again is caused by increased glucose spikes. There is a progressive nephropathy, that is long-standing postprandial spikes are what you see in patients that suddenly have slight creatinine elevation or albumin to creatinine ratio increasing. Albuminuria, eventual renal function decline. Retinal complications, fluctuating glucose levels, again mostly long-standing. Even if they were pre-diabetic, if they have postprandial spikes, it can start with the vasoendothelial growth factor. This causes increased vascular permeability, again causes the diabetic retinopathy picture over the long period of time. Nerve dysfunction, which is one of the most common symptomatic of high postprandial spikes, is from the neuropathic damage that is caused by advanced glycation end products and polyol pathway activation and impaired neurotropic support, usually nerve damage over long-standing periods of postprandial spikes. Even if the HbA1c is below 7.5, patients can have nerve damage. I've seen this from nerve conduction studies in patients with less than 8 HbA1c. Next. Okay, now measurements in a lot of places. Now, this depends on the kind of economic condition the patient is and how often they can do it. Because of most of my patients who basically come from a middle to upper middle class category, they usually go for fasting thrice a week and postprandial twice a week, mostly because all of them work. So there is the self-monitoring blood glucose, which is a 2-hour post-meal finger stick, and I usually give them a chart and they chart it and bring it back in 2 weeks or so. The newer, more expensive method, but what gives you a proper ideology of the spike, I have tried it with about 15 to 20 patients now. And now that the new CGMs actually give you direct data to the physician system, it's much easier for me to see the spikes coming faster. So is it for the patient. So the continuous glucose monitoring system, I think the Abbott Libre is the one that does it right now. They have come out with the direct to the physician one. So it's easier with a CGM, but slightly out of the affordable range for a lot of the population still now, especially coming to a country like India. Now, the key metrics about this, especially in CGM, what it shows is the time above range. That is, if the readings are above 180, and how long is the hyperglycemic exposure? Glycemic variability. There is a standard deviation and a coefficient of variation that quantifies the glucose fluctuation. That is, it gives you kind of a p-value or a median value of what is the median glucose level that it is there. Then incremental area under the curve. This basically means the total postprandial exposure. Is it under the normal curve or is it excursion over the curve? And how many times is one of the metrics that is seen. The last one is time in range. Now, this is the goal for control. That is between 70 and 180. That includes from fasting to postprandial. Under 180 is what time under range. More the time in range, better the control. So if the once we go forward, I can show it to you. Can we go to the next slide? All right, time in range. So postprandial, this is what shows high GI, that is the red curve, and low GI. Now, you're looking at the blood glucose level, the metrics are a little different. That is in millimoles, we are looking in milligrams. So 3 would be around 180. So time in range, the time in range for low GI, that is your proper control. The high GI, the time in range is much less. So that is a overall less controlled diabetic and requires more active intervention. Can we go to the next? Okay, measuring postprandial glucose and glycemic variation. Like earlier, self-monitoring blood glucose, that basically you get your fasting and you get your postprandial frequency and duration of hyperglycemic episodes, which you get rarely one or two. Again, depending on the economic stability of the patient, you try to get as many readings as possible. Peak postprandial value that you will understand from one or two meals, the initial treatment or the initial part of the week when you're monitoring. In continuous glucose monitoring, it is much superior because more than you pricking the whole time and checking and writing it down, this gives you an entire chart. There is the standard deviation and the COV, coefficient of variation measurement, gives you the mean variability from the median, how much is it going up and down, and also area under the glucose curve analysis, that is how many times has it crossed the baseline? How many times has it crossed, and how long was it over the baseline, and how long was the curve under the baseline? Time out of range and time in range. Next. The time in range is represents the percentage of time the glucose remains within 70 to 180, which is by CGM technology. This gives you a control way behind HbA1c, because obviously HbA1c is once in 3 months. Time within the optimal glycemic range. That is, once you know that your range is between 70 to 180 on a median level, and under the range, under the optimal range is, at least 16 to 17 hours in a day, it is under that range, you're reaching your goal. Goal is definitely to have a 24-hour control. Time above range. This is what is driven by postprandial spikes. That is hypoglycemic episodes, which are postprandial spikes. Time below range, hypoglycemic episodes requiring intervention. Again, if the OHA or the insulin levels that are being administered is much higher, then time below range is also a requirement for intervention, because clinically it would cause fainting spells and could be dangerous to the patient. Next. Recommended by ADA and international concession is metric. The metric value is primary goal is 70 to 180 more than 70% of the time, which is around 16 hours to 17 hours in a day. Time above 180 should be less than 25%. That is, it should not be more than 2 to 3 hours where it is spiking, and even the spike, the amount should not be much higher. Time below range should be less than 4%, and the patient should not have very high hypoglycemia points, and it shouldn't go much below 70. Even though it is written 4%, I would suggest that it come down to 1%. Time below range below 54 definitely should not be happening. Even though the guidelines say below 1%, my advice is it should never go down below that. And can we go to the next? The benefits of higher time and range is you have your microvascular protection. Every 10% increase in TIR basically approximately lowers 40% of your retinopathy and renal dysfunction. Daily function is enhanced because you have improved cognition, mood stability, and a sustained energy throughout the day, instead of having hypo episodes and then going into hyper. Quality of life, better the glycemic stability. Obviously, the patient themselves have confidence in their diabetes management, and the more anxiety and the more testing that patients do about to check if they have their complications are reduced. Then the therapeutic precision, that is the real-time glucose patterns, getting spikes and dips. All this is from CGM, and it personalizes a treatment adjustment. Yeah, next. Uh, the postprandial and time and range, the critical connections. The postprandial spikes is the primary contributor to time above range. Managing the PPG directly improves the overall time in range. And the integrated strategy would always be meal timing, the type of food, and the type of OHA or insulin the person takes, the method of taking it, and how much are they taking it. It is essential that the PPG excursions are brought down to TIR. Sorry. Yeah. The primary contributor time above range would be the postprandial spikes. So optimizing the time in range requires the excursions to be brought down. Let it be pharmacotherapy, let it be meal timing or food quality. Next. Okay. The targets for postprandial glucose would be for a non-diabetic, it should be less than 140. And for a diabetic, it should be less than 180. Individualization is essential because uh, talking about India, we don't talk about race, but age, the comorbidities, hypoglycemic risk, the life expectancy, treatment goal, and older adults with significant comorbidities require less stringent target. That is basically to bring down the hypoglycemic episodes that they might have. Next. Pharmacological approaches, many more are coming out right now. We have your rapid acting insulins, dosing for those, to match postprandial excursions, especially when the spikes are higher. We have usually treatment with insulin used to be basal bolus. Now there are patients who have spikes, especially those who use CGM. We have very rapidly or ultra fast acting insulins, which immediately brings the spike down, even though it is an added insulin, but it's not on a daily basis. Then you have your alpha glucosidase inhibitors, acarbose and reducose, which is mulberry leaf extract. It slows carbohydrate absorption, blunting postprandial peaks. The only side effect is some of them talk about bloating because of the slow carbohydrate absorption. GLP one receptor agonists, those reduce postprandial spikes through delayed gastric emptying and enhanced insulinotropic effects. So, more time for the insulin to act, even though the beta cell production of insulin is less. DPP-4 inhibitors, they provide a modest reduction in postprandial glucose through incretin enhancement, which is why it is always better to give DPP-4 inhibitors in combination with some of the other drugs. Meglitinides, those are short-acting secretagogues which target postprandial glucose with rapid onset and short duration. Select therapy based on hypoglycemic risk profile, overall HbA1 goals, patient preferences, and comorbidities. Combination is what gives you a optimal result. I would like to add to this that again, it depends on how the patient can actually monitor their glucose. So, accordingly, hypoglycemia can still be brought down, but hypoglycemia is always a risk to the patient. Yeah, next. The lifestyle strategies to blunt PPG spikes. Obviously, the meal composition has to be optimized. You always choose a lower glycemic index carbohydrates. You increase protein and fiber content, minimize refined carbohydrates. Now, this changes from state to state. It even changes from district to district in each state. Next is the portion and sequencing. That is, you control the carbohydrate portion, always have vegetables and proteins before carbs. And it always shows that when you have vegetables and proteins, it kind of has a filling effect. So carbohydrates are less after. And this shows a lower glucose peak. Post meal activity. Those who actually, it is quite prevalent in our community, a little older population also, they always nap after mostly lunch. Some of them even sleep immediately after dinner. All these causes increase in spikes. So always a 10 to 20-minute walk after meals. It improves glucose uptake and it has a strong evidence to bring down the spikes. Meal timing strategy. This, I think, rice eating population has a problem with because our state mostly we all have rice for lunch, large carbohydrate load, which is mostly during lunch, and consistent meal timing not possible for everyone. This goes to the lower strata of the economy to even the higher strata of the economy, and spacing meals appropriately. That is, having breakfast at 7 and then having lunch at 1 o'clock or 2 o'clock. That is a 6 hour gap. That causes either hypo or the increase in appetite causes a spike after lunch. Yeah, next. Key takeaways for clinical practice is the postprandial glucose contributes significantly to HbA1c, especially at lower ranges. That is when it looks like the patient is not heavy diabetic or is uncontrolled with HbA1c below 7.5. Still, the patient could incidentally be having spikes, which might increase the HbA1c later and increase complications. TIR, the real-time HbA1c, that is time in range, serves as a dynamic glycemic control metric. This will reduce long-term complications. It enhances patient quality of life, again based on CGM, but as it becomes more affordable, I think most of us would convert to that rather than glucometers. Active assessment and intervention to utilize the SMBG and CGM to assess postprandial patterns, then to apply a targeted lifestyle modification, change the drugs or titrate the drugs according to individual personal data. That includes insulin, secretagogues, OHAs, whatever the patient is taking. Personalize and monitor. Each patient requires a particular method of monitoring, and that depends on patient's characteristics. Like I said, that includes availability, economy, and patient motivation to check it. And real-time glucose data obviously optimizes the outcome the best. Next. And that's it. Thank you.
Thank you, Dr. Abhilash, for the insightful and clinically rich presentation, especially your explanation on how the glucose variability contributes to the complications and how CGM can help in, effectively managing the treatment decisions. That's very helpful. So we'll take the questions at the end after Manju finishes. I think Manju has a few more slides to talk about lifestyle and nutrition. So, sir, stay around till we finish off the talk. Okay, to introduce Manju, as I mentioned, is a good friend of mine. So we though we are in two different cities, we end up meeting often in a lot of clinical forums. Just to introduce to all of you who Manju is, Dr. Manju P. George is the chief dietitian at VPS Lakeshore Hospital, Kochi. She has over 20 years of experience in clinical and industry settings. She has a lot of experience in medical nutrition therapy, diabetes management, and patient education. As I had mentioned, she is actively involved in a lot of presentations in national and international level. Even the state level goes on doing a lot of education programs. She's a mentor for registered dietitian interns and takes up a lot of research initiatives. Qualification wise, she's a PhD and an RD, and she's a diabetes educator, certified diabetes educator, and has also completed FODMAP training in IBS from Monash University. She's an academic counselor from IGNOU, senior lecturer, nursing education. She has won a lot of awards and recognitions for all the times that she goes and presents, and leads a very extremely busy life. So over to you, Manju. We look forward to hearing your session, the focus on nutrition and lifestyle strategies to manage the glycemic peaks and prevent the crashes. Thank you.
Thank you, ma'am. Thank you, Dr. Esther, for the kind introduction. Thanks to Pulse NutriScience for the opportunity too. Really good to meet many of the delegates over here on this National or World Diabetes Day. Many of the awareness programs are also going on. And we know, in spite of all the awareness sessions and active involvement from the healthcare professionals, it is still alarmingly increasing. And as Dr. Abhilash rightly mentioned, it is because of the glucose excursions. The roller coaster is really going on its peak, and we need to see how we can manage the spikes. I believe many in this platform are basically doing the diabetes education. Counselors are there, dietitians are there, practicing students are there, aspiring nutritionists are there. So it will be good that we give practical advice or practical inputs to those whom we come across. And this is a small measure, a small effort in bridging the gap between the theory and practical. And let's see how we can do our level best in managing the spikes. Next slide, please. So in the last talk, we heard about time in range. It's not a new term, but it's really good to practice so that we can manage the HbA1c or the glucose spikes under control. And this is very well needed, and we have to maintain the optimal timing of glucose control in this particular timing. And that is very important. And that we know that the daily food choices directly influence the blood glucose fluctuations. It's not only the dietary aspects, but there is stress, sleep, activity, and everything was mentioned in the last presentation by Dr. Abhilash. So let's see how we can manage these spikes, and if not properly done, what will happen? The glycemic curve needs to be flattened. How this curve is obtained? It's basically when we plot it against the continuous glucose monitoring supports, and otherwise those who are doing the monitoring on regular basis, they can plot it against again the spikes or the fluctuations can be plotted in a graph and can be seen the range, and this will be supportive. There are a certain watches are there, or there is Bluetooth connectors are there, smart watches, and each device, people are having multiple devices, and this is very well documented and can be done. And what are the benefits? It reduces stress on the pancreas. When we control the glycemic spikes and glycemic excursions, the pancreatic stress is limited and oxidative damage can be minimized, and it supports overall metabolic health. Next slide. So, what could be causing the sugar spikes and crashes? Basically, the meals, the postprandial glycemic variations are happening with a large meal or a sugar enriched meal, or when there is no fiber added to the proper snack or meal. And in the even the absence of protein also causes the spikes. So there is the combination and qualitative consumption is really does matter, and the immediate effects of the spikes. There could be sudden energy dips might happen, mood swings are happening. Especially, we know there are people who experience when the sugars are going down, or when they experience hypoglycemia, there could be mood swings and irritability will happen. So these are certain indications that the spikes or the dips are happening, and hunger will be increased. There will be more craving towards certain food items or something they have to munch in, and the bulk meal impact is also more. Concentration issues will be there, and metabolic variations leading to oxidative stress and damaging the cells will also be there. The long-term impact of these glucose spikes will lead to insulin resistance, beta cell fatigue in the pancreas, and accelerate progression of diabetes complications that we know it very well. So next slide. So how can we practically manage these kind of spikes? Generally, we have seen or we have experienced that people take tea will be there as a light snack, and biscuits of multiple choice, and now the sugar-free biscuits or multiple brands are there. So that is one of the favorites of those who prefer to be having an in-between snack, or the rusk. Again, it's with maida or with some tutti frutti, it will be there, or sugar-free crackers are there. So all these things are just to give some filling. That's it. There is no protein or fiber content added to that. And there could be diet cokes or because they don't have any added sugar. So that's the justification what people give to that. But we know that there is no other functionality combined with these kind of food products, and it is just to give a satisfaction for that time alone, but not for an overall improvement. Instead of that, what all things can be replaced for the low sub qualitative or minimal qualitative snacks? Protein rich options are there. Definitely, they can have eggs with the yolk. I do suggest them to have at least 4 times a week to have the whole eggs. It's not that only egg whites has to be consumed by a diabetic or an overweight person, because the good fat has to go. That will give a satiety and filling effect. And additionally, they can have egg whites as a vegetable omelette or a burji form, or in the scrambled masala vegetable and scrambled form. So that will give more quantity, and also the filling effect will be there. And fruits, of course, we know the low GI fruits can support. But what happens if they consume more than one of the low GI fruits? That too, we know the size of an apple or guava in the current stage. That will be this much bigger. So that quantity when they consume, it's equivalent to one full meal, energy wise. So what can be done? It should be combined with some protein option like nuts or makhanas or curds or raita, something like that. And of course, a fiber and protein ingredient, if it can be added with the snack option too, that will give quite filling, and also the overeating pattern can be limited. Next slide. What all kinds of nutritional approaches we need to improve the time in range. That is very, very important, because it's not just one meal has to be taken. The time in range needs to be focused and monitored for the proper control. Macronutrients can be balanced. The aim will be less than 50 or 55% of carbohydrates. Protein, a high protein, definitely for a diabetic, that is needed. And fat can be normal. It's not that very low fat is required. It can be normal, but better to avoid the packed and processed food items, or even the multiple consumption of fried items. Minimal fat can be consumed as per the region specific. Basic oil can be used. Low GI foods can be taken, and wherever it doesn't increase the glucose spikes much, it can be selected. And when we consume a high GI food with a combination of high protein and high fiber, the glycemic index can be a little more lowered. For example, when we consume rice, basically the staple, whoever is having rice as staple food, when they consume it with fish or grams, green gram or Bengal gram, plus more vegetables, raita, something like that, the quantity of rice can be reduced, and these things, the rest of the food items can be additionally added, and it will make the GI of that meal come down. So likewise, the practical inputs need to be provided to the patient rather than advising them to be on a theoretical way. And meal sequencing is another important factor, which is, even though nutritionists and dietitians knew this, it's gaining importance in the recent past, where, as Dr. Abhilash also mentioned this, the first bite should be of the vegetables, and then the protein part, and then go with the starchy part. It doesn't mean that we have to finish the vegetable part at a stretch. First bite has to go with that. Why? Because the hunger hormone, satiety hormone, we have heard this, ghrelin, leptin, and all those. Those satiety feeling will happen when we consume fiber and protein in the beginning. And insulin spike will not happen. So the urge to eat more will not be there. So it's all hormonal and psychological control approach. It can be practiced, and it is much helpful also. So when they for a function, or even at home or in a hotel, when people consume the full meal, they can fill their plate more with vegetables first and protein part, let it be veg or non-veg, not much of the gravy part, but with the non-veg part and vegetable, the quantity has to be more. And after that, let them put the rice or roti in the middle of this platter. And then they can slowly start eating, and it will give a feeling of fullness too. Instead of that, if we consume a small portion of rice or one chapati at the beginning, psychologically we may not feel the fullness. We know from the beginning, we know its very quantity is much less, and I may not be able to fulfill my appetite, and that psychology works. Instead, if we fill the plate first and then add the carbohydrate part, it can make wonders. So small changes will do. Control portions and timing. Maintain constant meal sizes and regular eating schedules. It again, as the previous speaker said, it may not be practical for everybody to maintain a particular timing, but personalized nutrition can support to make their shift-wise changes, and also activity, sleep-wise changes also can be planned if a personalized nutrition care is provided. What is the impact of nutrition on? Next slide. Postprandial glucose and HbA1c. We know there is a remarkable impact on the in the levels of HbA1c with respect to post-meal glycemic variation, and how we can reduce the higher spikes of the glycemic variation. It is basically combination of foods like vegetables, fibers, and protein will support. Even when one person is not able to consume that much of vegetables as fiber source or protein, there could be another option. The functional food options are also there, which can be made use of. We have heard of soluble fiber options, and mulberry leaf extract is another functional food which is gaining into attention in the recent times. That can be added to the meals or post meal. So depending on the, again, the personalized approach is required here. How better it can be applied to control blood sugars depends. But as nutrition professionals, we can give options, that these many options are there. If the conventional pattern is not working, we can try out the control of the spike, control the spikes with these kinds of measures. So fibers will do definitely wonders in managing weight as well as in the diabetes excursions. Next slide. So weight management is also gaining importance. It's known from time immemorial that even 5% weight loss itself will have a positive impact on the diabetes management. So calorie deficit diet, many are aware of the calorie deficit diet, but when they do a deficit diet plan, protein also gets decreased. The energy will be reduced, sugars will be reduced, but at the end of the day, what happens? Tiredness will be there, muscle loss will be there, total functionality will be, the qualitative changes will not happen. So that has to be made into notice, and practical measures like adding high quality proteins, more fibers, activity enhancement also needs to be done with the calorie deficit diet plan. Smart choices include change the white rice options or the polished food items to soluble fiber added food items like millets or whole grains, where insoluble fibers are also there. Along with that, add protein and fiber sources. Fried snacks can be replaced with boiled pulses. Each city will have different forms of preparations like this. There are people who consume sprout salads. If raw sprouts are not convenient to certain population, they can steam it or microwave it or slightly saute it and take. And it can be mixed with some capsicum or other vegetables, green vegetables, even egg also can be added, so that it can be made appealing as a mid snack or even a meal replacement, provided there will be some amount of carbohydrates and good protein and fiber sources there. So these kind of alterations can be there. And sugary drinks, definitely, even people may not consume juices with sugar. They are very much aware of that. But what happens if juice is consumed without sugar? It's again a drink. Will finish in 1 to 2 minutes time, and the glycemic excursion will be much higher. So that kind of, and fruit shakes are there. There is another trend that a meal replacement, one whole platter of fruits people are consuming instead of one balanced meal. So that is also causing just intake of carbohydrates only, and no protein or not much of fiber is also there. Depending on the fruit selection, it will be, and the balanced pattern will not be there. So all these things will affect the glycemic variations. So this smart choice need to be taken into consideration. Next slide. The recent trend, or still it's going on, is a ketogenic diet, where it is very low carb pattern. The high fat and high protein will give the filling. That is also correct. But is it having a consistency? There, when we start a diet pattern or diet regimen, it has to be a part of the lifestyle too. It's not just a short-term benefit followed by a reversal of what was the previous weight and what's the previous sugar. It spikes too much when the pattern is not followed. That should not be the case. So the complications like hyperglycemia, micronutrient deficiencies, lipid imbalance, and sustainability concerns, all these things need to be taken into consideration when we go for certain fad diets. And it is not advised that strict or severe caloric deficit diet or a kind of timely changing fat diet patterns should not be followed. There should be consistency and sustainability maintained, and which will support in the long run and for a qualitative improvement in the system as well as for the metabolic changes. Next slide. Along with the caloric restriction, and also including the higher qualitative nutrient balance, the gut microbiota also needs to be taken into consideration, where pre and probiotics are equally important because if there are people who consume probiotics more, but their diet pattern will be very much erratic. So if we are not providing an atmosphere for the probiotics to grow, there is no point in taking these tablets. So soluble fiber rich foods, uh, curds kind of foods, and natural fibers and natural grains, that has to be in, and processed food items, colors, and too much of spicy junk foods can be controlled, so that the atmosphere for the probiotics to grow is maintained. And if needed, it can be, as per the medical advice, probiotics can be consumed. Otherwise, our diet has diversity and we have to make use of the better. High time we do a change in our own pattern. Next slide, please. And where there is no rocket science is not involved. One meal, if the person is having erratic meal timing, one meal can be changed. That is, if they are skipping breakfast, it can be with a low carb, high protein, good fiber pattern combination. Then slowly start mid meal snack, and the dinner timing can be maintained. So these changes can be done one by one at a time. So like that, the sustainability can be maintained. Then after achieving the goal, this has to be monitored. Then proper follow up with the clinician and with the dietitian, physiotherapist if needed, or with the regular activity pattern, sleep and stress management. All these things will support a better qualitative changes in the diabetes as well as in the lifestyle management. With this, I conclude, and many thanks for the opportunity and patient listening. Thank you.
Thank you, Dr. Manju, for those practical strategies in glucose management. We'll now open the forum for discussion. If you have any questions, you can put it up in the chat box, or you can raise your hand and ask. Putting them in the chat box will become easier. So if you have any questions, you can go ahead and ask. Okay, I'll start off. Dr. Abhilash, for you,
Yeah.
suppose you have a patient on CGM. How long do you think the patient has to be on CGM for us to, I mean, is it a lifetime thing, or is it a long-term thing, or just 1 month on CGM is enough?
Okay. Lifetime is mostly prescribed for people with type 1.
Okay.
Those
Okay.
that require all-time insulin management because their fluctuations are not like type 2 or any of the other type diabetics. Type 2 diabetics, now a lot of people who can afford it, they at least go in for 2 to 3 months. That is,
Okay.
till they get a proper HbA1c high increase in the TIR, and the goal is to have your time in range more than 17 hours. Most of them discontinue CGM after time in range is after 17 hours. So one module of the CGM comes with two of those coin pads,
Right.
and one is for 14 days. So you're looking at one module for a month, and that costs around 5,000.
Right.
So the whole cost of CGM would be around 15,000. And okay, so it's around 15,000 for 3 months. And once most of the patients I have seen, after they come under time in range, then it is just self blood monitoring, because economically
Right.
also it is still not viable for us. It is not covered by a lot of insurances.
Right.
So
Right.
that is it's a hazard. I mean, it is a hurdle for us.
Is it only, what are the, I mean, is it that the patient should have a HbA1c of above 7 for you to start recommending that? Or is there a range for you to recommend a CGM?
CGMs for high HbA1c, definitely I recommend CGM. Anything above 8,
Anything above
with
8?
anything above 8, I would, and also newly detected above 7.5 and all, because of the same PPG issue.
Mm.
We don't want to wait for 3 months to figure out that his or her HbA1c is actually increasing.
Right. Okay, so there's one more question for you only, I think. Can
Yeah.
CGM be used at home? What is the cost and is it available on rent?
Yes,
CGM.
CGM is the reason for CGM is that it is 24 hours on your body, and it can be used while you're sleeping, you're working, at all points of time. It really doesn't matter. The only problem with it is the one time you stick it on, if it comes off, then you can't reuse it. the panel, and older CGMs had a reader. The newer CGMs don't have a reader. It is directly connected to your phone, especially the newer phones which has something called NFC. Rent, no, because it is a one time use and throw. 14 days is done, that one coin is done.
Okay. Manju, I think the next one you can take it up. Do you recommend fasting? Is this has become a trend these days, but as a professional, would you recommend it? Or even a keto diet? I think she handled the keto diet, but yeah, fasting.
Yeah, it's a good question. And autophagy is the concept which is growing in now. For religious fasting, when we do 12-hour fasting from morning 6 to evening 6, that should be okay, but not on for a diabetic patient. That should be checked with the doctor and then adjust the medications and then do. For a normal person, if you are asking, weekly once fasting, but that should be with adequate fluid intake. That has to be taken. Proper water intake needs to be there. Even buttermilk can be consumed. So it becomes a hydration and body cleansing, and some mental well-being also will be there. Some holistic approach we can say. But before and after the fasting period, we should not be having a heavy meal. Should be the fasting has to be or some nuts and some small meal pattern has to be there. Should be digestible to the system. In that case, it is okay. But I don't suggest a complete fasting for body cleansing, that kind of activity, because body needs energy. We are all working and some of the other activity we are doing, so it's better not to do it on a regular basis, but weekly once as per the currently said pattern, it is fine. Keto diet, as ma'am mentioned, we have just covered. um, can we ourselves increase the dose of insulin, or let Dr. Abhilash, it
Yeah,
will be
I think,
better.
yeah, Dr.
Carbohydrate
Abhilash.
counting is, yeah. Huh.
Yeah, so Dr. Abhilash, maybe you can take that up. Can carbohydrate counting be done in type 1 diabetes? Can we ourselves increase the dose of insulin? Ourselves meaning as dietitians. Can
Okay.
dietitians increase the dose of insulin when they are advising to the patient and manage the carb counting? How do we do that?
Okay, carbohydrate counting is kind of tricky in type 1 diabetes. I think I've come across about 10 or 15 of type 1s. Problem with type 1, I've had one or two patients with Addison's along with type 1. These are
Right.
very tricky because each person's diet changes. So it has to be a very customized carbohydrate counting, because if you give them a whole array of things to do, which is standardized for someone else, they will definitely go into hypo, or they'll have like massive spikes. So with type 1, their meals have to be on the same count as like every meal should
Your
have the
voice
same type of
breaking.
count.
Yes. Go on, Dr. Abhilash.
Yeah. Sorry. So what is the second part of the
The
question? I
second
can't.
question is, can we adjust the dosage of insulin
Yeah,
ourselves?
you can, because we kind of train the patient themselves to adjust the
Adjust.
dosage. So definitely when they come to you, you can adjust it. But if the spikes are going up and beyond because of there is a change in their diet, because most of the type 1s are young patients. So you can't actually ask them to stick on to one particular diet. They will weigh off the diet some point of time. So when the spikes go on very high, because with type 1, it is very dangerous. Their spikes are above 300, 400. So when it comes to that, definitely they have to be managed by like either diabetologist or internal medicine. But the small spikes and small insulin dosage that can be brought up and down, definitely diabetologists can, I mean, sorry, dietitians can do it.
Right. Thank you. Manju, one more question for you. Do you want to comment on the role of Mediterranean diet for diabetes management?
Yeah, I will do that. And in the previous question, to add to Dr. Abhilash's comment, if we are confident in educating them on the carbohydrate counting, is as doctor suggested, we can plus 1 or 2 or 4 units of insulin. There is not much harm in managing. And if the patient is very much aware on the carbs counting, and as doctor said, it's very tricky in our Indian diet. There is no proper labeling, and we in our mind we may be showing one small potato and he'll be having a big potato at home. That count totally varies.
Yeah.
And I may be having a small idli and he'll be having a big idli, so then also count goes out of our control. But this with the proper pictures and portions, if we can explain to them, it will be really good, so that in their local practice they can do it. And with the diabetologists and endos, we have to work together so that we and both of us will have a similar opinion than two different opinions. That should be done as a multidisciplinary approach in this regard. That's what my suggestion is. Yeah, and regarding keto diet, I definitely do not
Mediterranean diet.
suggest. Yeah, this question is keto diet and a Mediterranean diet for diabetes management. Keto diet, no, because it is very low carb, but it has its own complication. But we can go for low carb, good protein, normal fat to modify the keto. Mediterranean diet is, it doesn't have much of a processed items, and recently the good comments on, and who will practice and follow this is another question. To talk, it's good to talk like this, and select the multi-grains and more fibrous vegetables, fruits, and so those things, and non-veg also, not in the processed form. So this is suggested, the pattern is suggested, and personalized nutrition management can support this kind of diets adjusted to the person's practice and activities. Yes.
Yeah. Manju, I'll come back to you. Dr. Abhilash, can you explain to us about the Sumoji effect and how do we manage that? That's pretty common among Indian patients.
It definitely is. Again, depends on which. It has a lot of geographic issues also when the effect comes in.
Right.
That is, it is a rebound to low blood sugar. But that usually I have seen a lot of patients, and especially in patients that take up insulin, this is where you have the hypo creating a problem. That is, patients having hypoglycemic episodes at, their meal time is changed and they have a little bit of hypo. They go and actually have carbs because it is it causes a immediate stabilization of the sugar. But what happens is it spikes in most of the patients with insulin. How do we manage it is, one, I would suggest that the meals and the meal timings remain the same. Now, in our scenario, it is a little hard to do this because we have situations like functions and all of this, and that kind of causes this spikes to happen. That is, a person goes into hypo and then it spikes up to hypo. In patients with on insulin, usually what I do is I always tell them to up the basal insulin before they go in for function, so that neither do they go into hypo, neither does it cause a rebound hyper. Patients with OHA, I would always suggest them to have the OHA only 1 hour, 1 hour or half an hour before they actually have a meal. That is how I usually do it.
Right. Thank you. Manju, back to you. In North India, fasts are very common. Women with type 2 diabetes are adamant about fasting. Any strategies for that?
it's our personal belief and personal decisions. So when fasting, definitely it's not suggested for a diabetic patient, but yes, definitely they'll do. The faith and religious patterns will be there. In such scenarios, it's better to discuss with the consultant, adjust the medications, and then do. That's what the suggestion is. It should be personalized. We can't say they should not fast. It's a
Yeah.
religious problem then. But it's if the mind is satisfied with such activities, that's really better. But they have to have a monitoring with the consultant's opinion. That's what is
Right,
required.
right. Dr. Abhilash, I'm coming back to you. Diabetes
Yep.
is a disease or a metabolic disorder. If it is a disease, what about gestational diabetes, which can be cured in 2 to 3 months? I mean, I think you can just highlight that about,
I think,
gestational diabetes. Yeah,
yeah, it's a metabolic disorder. No one would
right,
call it a disease. Now, the issue being gestational is due to the hormonal imbalances during pregnancy. There are a lot of patients I know who, after even though they are at higher risk to develop diabetes after down the road, I know a lot of people after the first delivery or even the second delivery, both of which they have had gestational diabetes. They stop using metformin or insulin, and once the delivery is done, they come down to normal postprandial fasting and even HbA1c. So for them, I would only suggest that they have constant monitoring. That is, at least do an HbA1c once in 6 months. And if it's climbing, then you start with the fasting and the postprandial.
right, right. So just to emphasize again on what Dr. Abhilash has said, it is a metabolic disorder. Gestational diabetes can just be a warning or a flag to keep monitoring the sugar levels even after the delivery is done. Okay, so Ramesh, do we take more questions or shall we wrap up? Because I think Manju and Dr. Abhilash have to, it's about 4:10. Shall we
I
take a
think
few
we
more?
should wrap up. Any of the
Yeah,
questions, what we can do, we can directly forward it to them.
right, right.
And then maybe the answers which we will be tracking and then forwarding to the individuals.
Right. I'm so sorry, participants who couldn't, the questions that I couldn't take up. But, it is during work time. Both Dr. Abhilash and Dr. Manju have stepped out. So, honoring the time, thank you so much, Dr. Abhilash and Dr. Manju, for this time. Thank you, Pulse NutriScience, for organizing this on World Diabetes Day. It has been lovely to have all of you and the participants to come on stage. And thank you. Thank you once again.
Thank you.
Many
On behalf
thanks,
of
ma'am.
Pulse,
Many
we
thanks.
thank
Thank you.
everybody for attending this
Thank you
webinar.
all.
Yeah.
Thank you.
Thank you.